Dr. Cook with us today. Welcome, Dr. Cook.
Thank you. Uh, is my audio coming through okay? Okay, I'll assume so. Great. Well, it's wonderful to be here. Today I'm going to be talking about how to use a learning health system approach for improving patient outcomes. And specifically, I'm going to be talking about how I've used this approach to develop more effective tobacco use treatments for veterans. So first, I just want to spend a little bit of time talking about some characteristics of the VA because the way it is structured makes it very suitable for using a learning health system approach. So there are 170 VA medical centers across the US, with 1,200 outpatient clinics, including about 1,400 total healthcare facilities, and it provides care to just over 9 million veterans who are enrolled annually. So it's larger than any US private healthcare system, making it the largest integrated healthcare system in the US. It operates as a unified network under, as you know, federal oversight. All VAs share a common EHR, common governance, and common mission. So these features enable us to engage in partnered embedded research in the VA that really support the broad and rapid dissemination of interventions and policies. So it's kind of a unique setting. So the learning health system approach was pioneered by the VA, and not only was it pioneered by the VA, but VA was the first to really rigorously apply LHS principles into patient care. So ultimately, the goal of the learning health system approach is to integrate data from multiple sources, from the EHR, from research, from clinical practice, directly from veterans, to ultimately improve veteran care in real time. So I want to talk about some additional key VA features that support the learning health system approach. Again, I noted it's a unified integrated system. So for example, regionally piloted interventions can be quickly scaled across the nation. The VA also has a really sophisticated data capture system that results from real-time monitoring of veteran outcomes. And for example, researchers can request de-identified data from the corporate data warehouse, and then they can analyze these data, and this feeds back into clinical operations. As I noted, it's also an embedded research structure where there are true partnerships between researchers, operational leaders, and frontline providers and veterans, I should say. Um, and I'll talk a lot more about this. There's also anyone who's been in the VA probably has noticed there's a culture for quality improvement. There are also specific learning collaboratives and networks. So there's operational partnerships between researchers and national program offices. There's also a program that fosters learning cycles. It's called Query, or Quality Enhancement Research Initiative. All right, so what is the impact of the learning health system approach in the VA? Well, it allows us to rapidly translate research findings into practice. And I just wanted to give a few examples of the successful VA programs resulting from LHS. So the Opioid Safety Initiative, REACH-VET, which is a suicide prevention program, and PCMHI, which is a primary care mental health integration. Okay, so let's break down what a learning cycle looks like. So it starts with using data to identify a clinical need. In the VA, this data often comes from the EHR, where we continuously monitor key performance metrics like treatment outcomes, suicide attempts, treatment use, deaths. And these metrics identify areas for improvement. So once data identify a clinical need, investigators partner with operations to produce evidence by conducting clinical trials and implementation research. So they partner with operations, with frontline providers, and with veterans, because again, the research is embedded. Okay, and this evidence will feed into practice change. So once sufficient evidence has been collected, evidence is translated into guidelines, initiatives, new clinical dashboards, and it's rolled out across the VA. These practice changes lead to improved care. Veterans experience more effective, patient-centered care that should be safer. And then we continue to generate new data from multiple sources, from the EHR, from veterans, from frontline providers, and new data leads to additional iterative changes in order to improve care. So before I get into tobacco treatment, I just wanted to give one example from ReachVet. It's just such a great example of a successful learning cycle. In 2020, the veteran suicide rate was 57% higher than in non-veteran adults. So thousands of veterans were tragically dying by suicide each year. And this, of course, made prevention of suicide a top VA priority. So there was a clear clinical need, and VA investigators partnered with operational leaders, and they ultimately applied some predictive analytics to identify veterans who were at high risk for suicide. And this led to practice changes. So ReachVet was developed and it alerts clinicians to reach out to high-risk patients. So for example, those with a substance use disorder. Other changes were made as well. They changed the suicide screening template. And these practice changes have led to improved care. There's earlier engagement for high-risk patients, reduced acute psychiatric admissions, reduced attempts, and more outpatient care. But of course, the VA is continuing to collect data so they can continue to improve care. Okay, so now we're going to transition to talking about the use of learning health systems to improve tobacco treatment in the VA. And I'm going to talk about 3 tobacco treatment learning cycles. So the first learning cycle involves providing tobacco treatment for veterans who smoke cigarettes and are not willing or ready to try quitting. We also call this motivation phase treatment. So if you hear motivation phase treatment, just think it's treatment for veterans or people not ready to try quitting. Okay, so let's start with the data. EHR and also lots of research show there's a high smoking rate in veterans. It's the #1 cause of death and disease in veterans and also just adults in the general population. Data also show that too few veterans use evidence-based tobacco treatment, despite the fact that the VA does an excellent job offering evidence-based cessation treatment. One of the reasons that not enough veterans engage in tobacco treatment is they're just not ready to quit when they're offered cessation treatment. So about 15 years ago, I started recognizing this clinical need, and there's a need to develop treatment for people not ready to stop smoking, so we can treat more people who smoke. This treatment should ideally increase their motivation to make a future attempt, and it should increase their likelihood of becoming abstinent eventually. We just need to give them a stepping stone to get there. All right, so now we're going to transition in the learning cycle to evidence and talk about evidence that has been generated regarding the benefits of motivation phase treatment or providing tobacco treatment for those not yet ready to quit. And again, this was motivated by a clear clinical need. Okay, so evidence synthesis can also come from non-VA research studies. So there was research I conducted with my colleagues at UW Center for Tobacco Research and Intervention, and also from a meta-analysis. And this research showed that if you offer treatment to people not ready to quit, it increases the proportion of people or patients who enter tobacco treatment. So if you offer side-by-side treatments to help someone quit, as well as a treatment that can help them make some changes, like reducing. If they're not feeling ready to quit, we increase the reach of tobacco treatment. And that's a really good thing because we want to connect more patients with effective tobacco treatment. This research also generated evidence that using this motivation phase treatment increases quit attempts and abstinence in people who initially say, I'm not ready to quit. So it gets them ready and then they make attempts. And then I thought it would be important to try and generate evidence for motivation phase treatments among veterans. So I, along with my VA team, conducted a merit-funded clinical trial in veterans not ready to quit. And this is a good example of embedded research. So we partnered with operational stakeholders at both the local and national level. So we worked in partnership with the National Tobacco Treatment Program Office and with the Madison VA Tobacco Treatment Clinic and with veteran stakeholders. And all of these partnerships really helps us ensure that the research is aligned with VA priorities and program office goals. We want to make sure it's important to veterans. And we learned that veterans who smoke very much wanted a non-cessation option. They had other meaningful goals. They wanted to make changes and they just weren't quite ready to quit. And we also want to make sure that the treatment is scalable in the VA. Going to give a really brief overview of the design of the study. I'm not going to get into the weeds, but we just completed data collection. So we enrolled 502 veterans at the Madison VA who told us they weren't ready to quit, but they were willing to be offered treatments for their tobacco use. It was a two-arm RCT that involved in what we called an enhanced chronic care treatment, where these veterans not ready to quit received repeated supportive phone outreach. It was quarterly, every 3 months, over 2 years, where we offered them cessation treatment or healthy changes treatment. So they could choose a goal that felt right for them, but they didn't have to join treatment. And standard care just offered one offer of cessation treatment a year, which is pretty consistent with VA care. The outcomes are going to be 2-year abstinence and treatment use over the 2 years of treatment access. So it was a pretty long study and cost effectiveness. I can share some preliminary data on treatment use. We haven't looked at abstinence yet. But for the standard care group, over 2 years, 11, almost 12% used cessation treatment. That's about what you'd expect in the VA. But in the enhanced chronic care group, the group that got the repeated outreach and offers to engage in a motivation phase treatment, in addition to cessation treatment, 33% entered cessation treatment. So that's really, really exciting. And 50% used the healthy changes treatment. So treatment use in the chronic care group was really high, and I'm really excited to see if this translates into abstinence. So collecting evidence for the use of these approaches in the VA among veterans not ready to quit. So I am starting to work with the VA National Tobacco Treatment Use Program Office on some practice changes. I have been for a couple of years, and I'll share these with you. So I collaborated with the National Program Office to develop a clinical pilot to provide NRT and counseling to veterans not ready to quit. And this was several years ago now. And this involved training VA tobacco interventionists to provide NRT and counseling to vets not ready to quit. We got to use treatment protocols developed in my VA lab and at UW CTRI. And this was initially rolled out to 7 VA hospitals across the country. I think this was about 4 years ago now. And I actually just read, I'm reviewing a new report on the state of tobacco use treatment in the VA, and it shows that 30% of VA facilities are following this treatment protocol that we developed. So, um, we've definitely made progress, but we need to keep promoting adoption. So one of the strongest levers for practice change is to put recommendations in an updated clinical practice guidelines. So I'm currently working with a group to update the VA DoD tobacco treatment use clinical practice guidelines. Um, and I'm really excited that there was enough evidence to include a new recommendation to provide NRT or varenicline to increase quit attempts and abstinence in veterans not ready to quit. So this is really exciting. This really can drive provider behavior, clinical workflow processes. So I'm really hoping this helps with efforts to disseminate. All right, so that's where we are with learning cycle one. So now I'm going to move on to a new learning cycle that I'm involved in the VA. Um, and this involves proactive outreach for veterans with mental health disorders. So, the data tell us that veterans with mental health conditions smoke at a very high rate, and they unfortunately use treatment at a very low rate. So this tells us there's a clinical need to connect more veterans with mental health disorders with effective tobacco treatment. Okay, so we are working to provide evidence regarding strategies that help more veterans with mental health conditions to use tobacco treatment that can help them quit. Okay, so what are we doing to gather evidence? So right now, I'm collaborating with the Tobacco Use Program Office on a clinical pilot. I've been doing this for the past couple of years. So another clinical pilot that developed a proactive outreach approach to contact and provide treatment to veterans with mental health disorders. So this approach is different than the typical point of care treatment offer model in the VA. So typically, tobacco use treatment is tied to referral following annual clinical reminder during a visit. So the goals of this clinical pilot are to gather some additional data. We're trying to increase the number of veterans with mental health conditions receiving evidence-based tobacco treatment. And then we need to determine how to effectively implement proactive outreach in VA. So, for example, we need to determine the optimal protocol to engage patients. How many calls do you make? What should the script say? We're determining the staffing, clinical and training needs for VA. And what are the best practices for integrating proactive outreach with current treatment resources? And I thought I'd give you a snapshot of where we are. So we rolled out in 3 sites about a year, yeah, a year ago, Minneapolis, Palo Alto, VA, and Texas Valley, Coastal Bend. We actually just rolled out in Madison a month ago and 2 other VAs. So that's exciting. Um, and we found that 38% of veterans received a referral for tobacco treatment. And these were veterans who declined any tobacco treatment at the time of their tobacco screen 1 to 2 months earlier. So I think this is really impressive. And at the first follow-up, 45% reported a reduction in tobacco use and 15% reported abstinence. So really promising outcomes. So some questions have emerged from this clinical pilot that really require additional evaluation. And so I'm partnering with my colleague Steve Fu from Minneapolis VA to develop a PCORI proposal, and we're going to compare different proactive outreach approaches in veterans with mental health conditions. Um, and so we just need more evidence, and our hope is that the evidence produced by these studies are going to lead to practice changes, improve care for vets with mental health conditions. And I just want to emphasize that the PCORI project is a direct outgrowth of the work I've done with the program office. So I'm really grateful for that collaboration. Okay, finally, one more cycle. This one's pretty short because I'm very early on in this process. Um, but so there, in terms of data, we know that, when you offer NRT to people not ready to quit, you definitely increase treatment reach, but it only modestly boosts abstinence. So there's a clinical need to increase the effectiveness of motivation phase treatment. We need a more effective treatment. So I approached the VA tobacco treatment program office with an interest in comparing whether varenicline might be more effective than NRT in veterans not ready to quit. Um, they were very interested, and they partnered with me and my colleague Neil Duran on this trial. So we were awarded a merit multi-site trial that's going to enroll in Minneapolis, Durham, and San Diego. So this is just another example of embedded partnered research. We're just starting to get this trial off the ground. So that's all I have to say about that. Um, and so I guess just wanted to step back and think about a couple lessons learned. Um, using the learning health system approach to guide my research has definitely boosted its impact. And I think it's made it really gratifying for me. I really get to see this direct connection between my research and patient care. And then patient, care definitely informs my research and vice versa. So what are some of the things I've learned along the way, or what advice would I give for anyone who wants to do this type of research? Really form relationships with national partners, volunteer for committees, just kind of put yourself out there. Communicate your study findings that might inform program office policies. Form real partnerships with patient stakeholders. Um, Reach out to program offices to get feedback on research ideas. Ask about their priorities. And I find this one really helpful. I read program office reports and guidelines all the time. It gives you a roadmap for what they want to see happening in VA, and that can be incredibly helpful. So those are just a few thoughts about lessons I've learned. Um, and that's all I've got. But I would love to hear any questions or thoughts, or if anyone else has a nice example of learning health system research that they've done, I'd love to hear about it.
So feel free to either put your question in the chat or come off mute and ask your question directly.
I have kind of a specific question. I'm Allie. I work in ICTR's Recruitment and Retention Resource Center. So my colleague and I often talk about sharing out and disseminating your results. Um, would you be able to just quickly share how you kind of do that, or best practices or suggestions that you have, especially around VA?
For sharing results.
Yeah.
Yeah, I mean, I've formed a relationship with, for example, the deputy director of the Tobacco Use Treatment Program Office. So I often directly reach out to her to share results or thoughts, just because I've kind of formed that relationship. Um, I know when I've presented at national conferences, occasionally I get approached by someone from the VA, so that's another way to do it. Um, but it really is kind of, and then as I've been asked to participate in, say, the VA DoD CPG, I naturally share results from my research that they might not be aware of, as well as part of like the clinical demonstration pilots. Does that answer your question?
Yeah, I think um,
It can be
we do.
hard to figure out how to share results. I really understand that.
Yeah, and it's just something that I think a lot of people aren't thinking about until they get to that point, or even back to participants as well. I think is something that not everyone is always considering, because they're usually, when they come to us, they're more concerned about finding those participants first.
Yeah, it's interesting because I'm starting to engage in the Picori application process, and they have more of a, I think, a built-in feedback system where you work with, for example, I'll develop a veteran CAB, and I'll be giving them feedback throughout the entire study, including about results. And I'm not sure we have that same system developed in VA yet. So it's a great point. We do have veteran engagement boards, and I have heard that they like it when researchers come back and meet with them to tell them about results, but I think it's not required, but it's something we should all think about.
I've never thought about that. That's a good idea for that
Yeah.
board. Huh.
Are there other questions? Okay, Dr. Cook, I want to thank you so much for presenting today. This was really interesting research, and we wish you the best with your new projects, and we hope you come back again in the future to share those results with us, or the lessons learned.
Yeah, be my
Um,
pleasure.
all right. Thank you for joining us today. We appreciate it.
Thank you.